we are going to listen a lot of ENT, pharmacology, and bits of clinical aspects, and it will be a complete privilege, sir. We are waiting to hear your presentation. So, kindly continue.
Yes, good evening, sir. Sir, I'm myself Dr. Abhay. Sir, I'll be speaking today on drug therapy. Sorry for the delay because of some logistic problem and net connection. So I'll be starting with the drug therapy in otology right now. Okay. These medicines they are commonly used in otology. The presentation will take part in the drug indication, contraindication, and the side effects of commonly used drugs. The type they can be divided into antibiotic which are used for to reduce the inflammation, the local analgesics to reduce the pain in the ear, steroid to treat inflammation of the skin of the ear canal, wax emulsifier to loosen and remove the ear wax, and then there is combination of ear drops, otitis media and otitis externa. Today we'll be mainly dealing with the antibiotic part uh, and the ear drop. What about the ear drop? There are various categories in which the ear drugs they can be divided into corticosteroids, antihistaminics, decongestants, antibiotic, and antifungal. Here we'll mainly dealing with the antibiotic and antifungal part. The mechanism of action of various antibiotics. The penicillin, they have a bactericidal action. They inhibit the cell synthesis by preventing peptoglycan and cross bridges. The penicillinase sensitive penicillin have a greater spectrum of activity than the beta-lactamase resistant drug. The cephalosporin among the antibiotics, they are bactericidal like the penicillin. The macrolides, the erythromycin, they act by inhibiting the cell wall synthesis. Metronidazole, they initially used in protozoal infection but found effective against anaerobe bacteria. Ciprofloxacin is the quinolone and acts both stationary and dividing bacteria by inhibiting the DNA gyrase, an enzyme that compresses the bacterial DNA into supercoil. Hope you are able to hear me. Is it okay?
Yes, sir, we are able to hear you.
Okay. Penicillin is GNB. The penicillin is the traditional drug of choice for treatment of pneumococcal and streptococcal infections. The penicillin, they have a wide range of safety. It is associated with hypersensitivity reaction in approximately 5% of patients. This could be treated with antihistamine, but generally, rather than giving antihistamine, they are generally stopped rather than doing anything else. The penicillin, they inactivated by the beta-lactamase enzyme, and they attack the cell-active molecular ring. The anti-staph penicillinase resistant penicillin, they are of various types: methicillin, oxacillin, cloxacillin, dicloxacillin, and nextillin. Among this, the methicillin was the first penicillin to be discovered, and that resisted the hydrolysis by penicillinase. The oxacillin, cloxacillin, dicloxacillin were subsequently developed for oral use. They were more effective than methicillin against staph. Methicillin-resistant Staph aureus are resistant to this entire group plus all the beta-lactam antibiotics. The MRSA refer to the increased prevalent strain that are resistant to the entire group plus the beta-lactam antibiotic. Aminopenicillin. Aminopenicillin, they are ampicillin, amoxicillin. Aminopenicillin, they are active against staph, streptococci, and pneumococci. They have increased activity against many gram-negative organisms, H. influenzae, and Proteus mirabilis. The aminopenicillin they generate rash-type reaction. The streptococci resistance is induced by penicillinase. The gastric acid they destroy the ampicillin, but amoxicillin is administered after meal in the meal time, while the ampicillin is destroyed by the gastric juice. This is the difference between ampicillin and amoxicillin. The ampicillin is destroyed by the by by gastric juice, while amoxicillin, on the other hand, is given in between meals, between ampicillin and amoxicillin. Then augmented aminopenicillins, the amoxicillin plus potassium clavulanic, the ampicillin plus sulbactam. These are various combinations. They are effective in treatment of acute otitis media and sinusitis. They are effective against otherwise resistant bacteria as H. influenzae, M. catarrhalis, and Staph aureus, except MRSA, methyl resistant Staph aureus. The combination has proven to be very difficult in treatment of acute otitis media and sinusitis. The combination of this combination is very effective in treatment of acute otitis media and sinusitis. Gastrointestinal side effects like nausea, vomiting are drawbacks to the oral use, but they can be minimized if the drug is taken at meal time. The parental, you just get the point, the amoxicillin and ampicillin, the parental equivalent to amoxicillin and clavulanic, which is given orally, while ampicillin and sulbactam is given IV. So just take this different. The oral combination is amoxicillin and clavulanic, which is generally given oral. You know it very well. While ampicillin and sulbactam, they are given IV. So amoxicillin and clavulanate are the oral substitute of ampicillin and sulbactam, which is given IV. They are effective against both MRSA, resistant as H. influenzae, except MRSA. Then anti-pseudomonas penicillin. They are ticaracillin plus potassium clavulanate, piperacillin, and piperacillin plus tazobactam. These agents, they are effective against Pseudomonas aeruginosa, Proteus, E. coli, Klebsiella, and Bacterius fragilis. Hope the audience is able to hear me.
Yes,
Sir?
yes, sir. We are able to hear you, sir. Yes, sir.
What about the rest of the audience? They are able to hear me, sir.
Yes, sir.
Is it? Am I audible?
Yes, sir. You are very articulate and audible.
Thank you. Give me better. So these agents, they are effective against Pseudomonas, Proteus, E. coli, Klebsiella, Enterobacterial, and Bacterial fragilis. They are effective against. They are inactivated by beta-lactamase, including penicillinase from Staph aureus. That is why beta-lactamase inhibitor are added in these cases. Anti-Pseudomonas penicillin. For infection of head and neck, they can be administered only by parenteral route. These anti-Pseudomonas penicillin, they can be administered only by the parenteral use. They are used in treatment of malignant or necrotizing otitis externa and other invasive Pseudomonas infections. These drugs are of value in all these cases because of they are able to, in the intracranial spread, they are able to reach the site of infection. For serious infection, for serious infection, they are usually combined with aminoglycosides like amikacin, tobramycin, and gentamicin. Since the synergistic effect occurs against Pseudomonas, and resistance is less likely to occur. You get my point? For serious infection, these anti-Pseudomonas penicillin, they're combined with aminoglycosides like amikacin and tobramycin or gentamicin. Since the 2 plus 2, 4 like this, the synergistic effect acts as a resistance barrier. If given alone, it is less effective. When combined with aminoglycoside, it is 2 plus 2, not 4 but 5. The synergistic effect, they help in prevention of resistance. So that's why these anti-Pseudomonas penicillin, they are combined with aminoglycosides to prevent resistance. Then I'll be dealing with cephalosporin beta-lactams. They can be used as penicillin substitute. They are cheaper than as a penicillin substitute to treat staphylococcus, except methicillin resistant Staph aureus, streptococcal and penicillin-sensitive pneumococcal infections. They are first generation cephalosporin. Now, in general public, lay public, the public, they think, even among medical students, they think the first generation is less effective than second generation. Second generation, the power बढ़ गया. Second generation is more effective than the first. Then third is more effective, and fourth, and so on and so forth. Even in the layman public, they think that if the cost of the medicine is higher, so the power is more. But this is not the case. The first generation, they have been so defined because they are active against gram positive, because of the spectrum. The cost of the medicine is generally, if any medicine is new in the market, they are generally costly because of the R&D which has been done over a period of time. When it is produced on a large scale, the cost of the medicine, it decreases. So power medicine ki zyada hai, first generation ki zyada hai, second generation, this is not the case. The first generation has been so denoted because of the spectrum it touches and the way it was discovered. So the spectrum, it has been generated according, because it is mainly against gram positive, the first generation. And it has, and as far as the cost factor is concerned, new medicine, because of massive amount of money which has been poured because of R&D, they're generally costly. So the cost of the medicine and first generation and second generation have nothing to do with the power of the medicine. It is more in relation with the spectrum of the disease which it covers. So first generation cephalosporin, they are effective against gram positive cocci, the strep pyogenes, that is gram hemolytic strep, GABS, streptococcus pneumoniae, and streptococcus pneumoniae, and strep aureus. They are effective against mainly gram positive strep pyogenes, strep aureus, and streptococcus pneumoniae. The treatment and prevention of strep aureus are the greatest use of this agent. It is very, very effective against the strep aureus. So this is the main. Previous slide only. So this is the main benefit of this. It is mainly effective in gram positive. They act against the strep aureus. The aankh band karke you can give this medicine in case of strep aureus. The resistance is so low. Most strain of gram negative, it is definitely effective against gram positive, but in few cases it is also effective against gram negative strain. Gram negative strain like E. coli, Proteus, but to a lesser extent. They are positive in all the cases of gram positive, and to a lesser extent in gram negative like E. coli, Proteus, but it is somewhat effective, but less sensitive. But they are not effective against Enterococcus and Pseudomonas. It is not effective. This first generation is not effective against Pseudomonas and H. influenzae. So it is not a positive. It is effective against gram positive, less so against gram negative, and not against H. influenzae and Pseudomonas. The cephalosporin, the cefazolin, the main drugs are cefazolin, cephalexin, and cefadroxil. The second generation cephalosporin, in this they have included cefamycin also, because generally it was there have been some ambiguity whether it is in second generation or third generation, but it has been included cefamycin. The main compounds here are cefamycin, cefoxime, cefotitan, cefaclor, lobrasef, cefocoxil, and cefuroxime. They are useful in treatment of H. influenzae. This second generation, they include, by first generation was not effective against H. influenzae. This is effective against H. influenzae in acute otitis media and sinusitis, and are also effective against strep pyogenes. They are less active, unlike first generation. The second generation, they are less active against strep aureus. The cefuroxime is the workhorse of this second generation. Cefuroxime, it is given both in oral, as in septine, and in parenteral dose. It is active against most of the H. influenzae, as I said earlier, and ampicillin resistant strains. Cefaclor is the least potent among all this, among all the drug which I have mentioned. Cefaclor is the least potent, and cefuroxime is the most commonly used. It is best absorbed when taken with meal. The cefuroxime is best when it taken with meal. and is the only second generation cephalosporin which has good CSF penetration, unlike cefaclor, levracef, cefuroxime, cefoproxil. Cefuroxime, they crosses the blood-brain barrier, and in case of meningitis and all this infection, they have a role to play. It is the cefuroxime is most effective in acute otitis media and in sinusitis. Now dealing with the third generation. The third generation cephalosporin, unlike the second generation, they are generally given orally and as well as in IV form. Cefixime, cefotaxime, cefadizine, cefpine, and ceftriaxone. These are the main drugs which are being used. They penetrate CSF very well. They cross the blood-brain barrier. Unlike better than second generation, the effectivity of this third generation is better than the second generation. Though second generation among only cephozine they crossed it, but here all the drugs they cross the blood-brain barrier better than the second generation, and they are quite effective. They are able to penetrate into the CSF and cross the barrier. Then fourth generation. Then the other beta-lactam agents are carbapane, meropenem. They cross a broad spectrum antibacterial activity useful for treatment of serious hospital-acquired and mixed infections, but they can be given only by parenteral route. I'll be monobactam. They are azithromycin used for treatment of aerobic gram-negative infection as a substitute for aminoglycoside, effective against H. influenzae and gonorrhea. The experience in the treatment of CSF is limited. Monobactam. There not much study has been done on this. Then I'll be dealing with macrolides. Macrolides, they are the commonly used. They are erythromycin, sulfixol, clarithromycin. Among erythromycin, they are effective against streptococci and pneumococci. They are very effective against streptococci and pneumococci. Erythromycin alone as a treatment because of its narrow spectrum of action, erythromycin alone as a treatment of otitis media is not given. Erythromycin, they are effective against infection against Mycoplasma pneumoniae, Chlamydia, and Legionella and Bacillus pertussis. But they, as a single agent, the macrolides, especially erythromycin, which is among the most commonly used, the results have been disappointing. They are generally not given simply as in otitis media, though in upper respiratory infection, the role of erythromycin is better. They have resistance. Given alone, the resistance they occur quite. Why is resistance is quite fast? They are not recommended for treatment of S. pneumoniae and H. influenzae, which is quite prevalent. So, it may be given along with other drugs, but not alone. Macrolides, erythromycin. Then clindamycin. The clindamycin, it is effective against all streptococci, most pneumococci, and most penicillin-resistant Staph aureus. It is a drug of choice for treatment of osteomyelitis. The activity against anaerobe infection is also quite significant. The combination of clindamycin with gentamicin covers the three main contaminating infection of head and neck: the staph, the anaerobes, and Pseudomonas. So this forms the bulwark of all the medicine which we give in ENT in case of discharging here or post-operatively. It covers the staph, anaerobes, and the Pseudomonas. Combination of clindamycin with gentamicin. If we add the metro also, so it covers the entire spectrum of staph, anaerobes, and the Pseudomonas. Oral clindamycin, they can cause nausea and vomiting, so it's not given. The use of clindamycin is followed by gastroenteritis and diarrhea. So generally, it's not so. Generally, can be given, but it causes nausea and vomiting. It is not useful in intracranial infection because of poor penetration of blood-brain barrier, the clindamycin. But it is a drug of choice in treatment of osteomyelitis and has activity against anaerobe infection. Anaerobe infection, as you know, It is mainly gram positive, gram negative, but anaerobes also have a significant effect. So clindamycin, they can be given as a in anaerobe infection, and with combination of clindamycin with genta covers the staph, anaerobes, and pseudomonas. So you should bear this in mind. Tetracycline. Earlier, this was the before the advent of aminoglycoside. This formed the bulk of all the treatment which was given. They are mainly minocycline, doxycycline, used for treatment of acne, for prevention of trial diarrhea, and for non-specific treatment of flu. Empirically used in topical mixture in gargling to relieve abscess, stomatitis, and other mouth infections. They can be given. So you can bear this in mind. But it should not be given in children because it causes brown discoloration. Tetracycline, it should not be given in children in growing age till the age of 10 to 14 years because it causes brown discoloration of teeth in initial part of life. So it should not be given. And but the other disadvantage is most strep and pneumococcus strain have become resistant to tetracycline. But it can still be given. It is bacteriostatic, can still be given in mouthwashes, in abscess ulcer, and in Vincent angina, but should not be given in children. Tetracycline. Chloramphenicol. They are broad-spectrum antibiotic that crosses the blood-brain barrier. The penicillin-resistant strain of pneumococcus are fully resistant to chloramphenicol. The penicillin, so it is not effective against penicillin-resistant strains of pneumococci. Aplastic anemia caused by chloramphenicol can be irreversible and fatal. So this is a very grave consequence of this. It causes aplastic anemia, and because of this, this drug has been stopped in many of the European countries, but somehow or the other it is still persisting. And so this is reserved for life-threatening infection that poses a greater risk than the inherent use, because the drug itself, as in medicine, if you can do no good, do no harm. If you cannot do anything good for the patient, do no harm. So when you give the chloramphenicol because of its inherent problem that it causes, so you should be very careful rather than causing harm to the patient. So you have to take the call whether it causes benefit to the patient or whether it is beneficial to give chloramphenicol or not. It is also quite hazardous to the fetus, so it should not be given in pregnant females also. Aminoglycosides. They are of special interest to ENT because they are they are quite commonly used. They are very commonly used in most of the medicines because generally they are given in IV form, not in oral form. But because it is of interest to ENT, why I said because it causes ototoxicity. So they have a tendency to cause ototoxicity. How they cause? They bind to the ribosome in the same manner as tetracycline. The mechanism of action is same as tetracycline. It binds to the ribosome in the as in case of tetracycline, and it is ototoxic. The streptomycin. This is commonly used drug in anti-tuberculosis and is also in bacterial endocarditis. Clindamycin, when you give it, you have to check whether the advantage and disadvantage outweighs the benefit. Neomycin, it is a topical agent against broad spectrum gram positive and gram negative therapy. Pseudomonas is generally resistant to this neomycin. All aminoglycosides, they are ototoxic and nephrotoxic, but can be used safely if doses and renal functions are managed. And the drugs are not well absorbed after oral administration, and they cross the blood-brain barrier poorly. So because of this and side effect of ototoxicity, it is not given orally and it is only given uh, IV. And one more thing is very common in the spelling of all streptomycin, kanamycin. In gentamicin, it is I. Most of the books, even in few of the European books and most of the Indian books, they spell gentamicin GENMATAMY. It is not MY, it is MICIN. So, but since the amount of wrongdoing is so much, most of the books they have mentioned gentamicin as Y. It is not Y, it is I. It is gentamicin. So but if you write Y, it doesn't matter because most of the books they have been writing in Y only. But I still remember when I used to in Goodman Gilman in the old edition, it was specifically mentioned it is not Y, it is I. Since I remember it, I just thought to tell you this. Now, quinolones. Quinolones, they are broad-spectrum antibiotic used for treatment of multi-drug resistant bacterial infection. They are anti-pseudomonas quinolones. They are ciprofloxacin, ofloxacin, levofloxacin. Their advantage of oral administration, they are effective against pseudomonas. Unlike aminoglycosides, the quinolones, they are not ototoxic, so they are very commonly used. The they are orally administered. The most important thing, orally administered for pseudomonas, for skin infection. They are they form the bulwark of your OPD practice because it is orally given and it is effective against pseudomonas. Then the respiratory, the topical, in fact, the topical in this side, will go again. The topical ciprofloxacin, the topical use of ciprofloxacin is superior to parenteral gentamicin. You got a point. In ear infection, if the ear is discharging, if there is there have been a school of thought which has been telling the topical ciprofloxacin is as effective as IV gentamicin in case of pseudomonas infection. So you can take it for granted. So people just generally don't write eardrop. The ciprofloxacin eardrop is as effective as IV antibiotic of gentamicin. So you should not forget this thing. This has been quoted quite in few of the books in archives or otolaryngology in recent edition also in 2000 edition also. So you should not forget to should not back out from using ciprofloxacin. It is very effective because it acts directly on the site of action and it is as effective as IV gentamicin. It has been quoted. Now respiratory quinolones. They are levofloxacin, gatifloxacin, moxifloxacin, gemifloxacin. They are useful in treatment of respiratory and pharyngeal infections because of their expanded activity against gram-positives such as Staph pyogenes, Staph pneumoniae. They are used for treatment of acute otitis media, pharyngitis, tracheobronchitis, and orally administered. They are well absorbed and widely distributed throughout the body tissue. They are well absorbed and most effective orally administered antibiotic. This is the respiratory quinolones, levofloxacin, gatifloxacin. They are the most effective orally administered antibiotic to treat multi-drug resistant penicillin infection. So it has a very wide spectrum of action and is among the most effective oral drugs which can be administered. The respiratory quinolones, especially the levofloxacin. Now the disadvantage, they are very far and few. It causes rashes, which is more common with gemifloxacin. It has it causes rashes, which is it causes in widening of QT in the interval. So you should be aware of all these problems. The pneumococcal resistance to quinolones, the resistance is quite low. So it has a wide spectrum of action and the resistance is quite low. Can be used safely. Only small it causes widening of QT intervals. Then vancomycin. Vancomycin, it has ototoxic potential. It is useful for treatment of methicillin resistant staph and penicillin resistant pneumococci in combination with third generation cephalosporin. The activity of vancomycin limited to gram-positive bacteria, not absorbed by GI and too painful for IM administration. It may create chills, fever, rash and flushing, red man syndrome, used for the shortest period possible. Dose 2 grams per day for serum, vancomycin. Daptomycin once daily to vancomycin for treatment of MRSA and methicillin resistant staph epidermis, so daptomycin, but it is generally not used in because of cost and other factors. Activity versus Staph aureus is similar to vancomycin, may create creatinine phosphokinase level leading to muscular discomfort, should be administered slowly. Linezolid. It is alternative to vancomycin for treatment of MRSA infection, important because it can be given orally, but at present it is quite expensive. Expensive it is why? Because it is less used and over a period of time, it is more, if all the doctors start prescribing, so it will become, the cost decreases. It is also active against gram-positive bacteria such as S. pneumoniae. It tends to raise blood pressure in patients taking oral decongestant and causes thrombocytopenia. Metronidazole. This is also a drug which is very commonly used. It is it is effective against protozoal, oral spirochetes, and almost all abigotes anaerobes. Anaerobe, this is a drug which is effective against anaerobes. Bear in mind, in all the cases in uh, mastitis and ear and intracranial infection, you have to give this metronidazole as a part of a treatment. It has promptly relieves the pain of multiple pharyngeal and tonsillar ulcer of Vincent angina. Can be effectively used in combination with penicillin, cephalosporin, quinolone for treatment of mixed infection. Tonsillitis, sinusitis, infected cholestoma, wound infection, and deep neck abscesses. It penetrates the blood-brain barrier well and is useful against brain abscess from coronary otitis or in case of cholesteatoma. Its primary therapy is it penetrates the blood-brain barrier and it is used in chronic otitis and cholesteatoma. The primary therapy for antibiotic-induced diarrhea. It is much less expensive. It's always used because it's much less expensive. The spectrum of action is same as in few of the infection like vancomycin, but it's less expensive, so can be used very well. It is it can be metronidazole can be induced orally also and can be intravenous also, long acting, and effective dose is 1 gram once daily. It has a long safety record in adults, but in children the it may cause anti-abuse type interaction and especially with alcohol also. So these are one of the few side effects that metronidazole causes. Then rifampin. It is a potent antibiotic against Staph aureus, pneumococci, Neisseria. Resistance to rifampin occurs quite rapidly during therapy. It concentrates in nasopharyngeal secretion and enter white cell which may be harboring the bacteria. Useful in treatment of nasopharyngeal carrier of Neisseria meningitis H. influenzae for prophylaxis against meningitis and epiglottitis. Mupirocin. It is topical antibiotic with activity against Staph aureus, including MRSA, Staph epidermis, Staph pyogenes. It is approved for treatment of impetigo as an ointment applied twice daily. It is effective for nausea in treatment of Staph aureus, including the carrier state. Mupirocin ointment used for treating skin injuries also. Sulfonamides. Sulfonamides, their antibacterial activity against most strains of H. influenzae. Sulfonamide and erythromycin combination used to treat acute otitis media and purulent rhinosinusitis. Trimethoprim and sulfamethoxazole combination is effective against Staph aureus, including MRSA. You should remember this trimethoprim and sulfamethoxazole combination is very effective against Staph aureus and MRSA. Main disadvantage, lack of potency when used as a single agent. When used alone, it is less effective, but when it is combined, one is bacteriostatic, they have a bactericidal action. So main disadvantage, lack of when used as a single agent, it is bacteriostatic. When combined, they have a bactericidal action and effective against Staph aureus and MRSA. Skin eruption and morbilliform rashes, these are one of the few side effects. And aplastic anemia may also occur in few cases. Antifungal. Antifungal amphotericin B, flucytosine, azoles, ketonazole, fluconazole, voriconazole, itraconazole, and fosfonazole. They are among this. I will be dealing only with amphotericin B. Is the most effective against mycotic infection. It has a broad action against Candida, mucous infection. It is administered intravenously, intrathecally, and in case of intracranial infection. Anemia is commonly seen, but is not. It is reversible. Topically, it can be given in fungal sinusitis as a nasal rinse. Amphotericin B. It can be used in recently during Corona period. It was quite common. In fact, it was out of stock for quite some time. Then ketonazole is the oral drug to treat chronic mucocutaneous candidiasis. So ketonazole, the dose is 400 milligrams once daily. The fluconazole, it is preferred oral and intravenous antifungal treatment to oropharyngeal, esophageal, and vaginal candidiasis. Oral amphotericin, uh, oral amphotericin, and this it may be used as a orally also. Drug interaction is similar to ketoconazole. The dose is 150 to 200 milligrams. And then subsequent day it is 100 milligrams. Itraconazole, which is also commonly used, it penetrates poorly into the CSF and generally not used. It is used in case of Aspergillus infection only. The three formulation capsule, they are orally, it is itraconazole, it can given orally, it can given as a capsule, it can given IV also. So this is the advantage of this. This is also one of the antifungal agents. Then antiviral among acyclovir, Zovirex trade name. It is effective in mucocutaneous herpes simplex infection in immunocompromised patient. 40 milligram, 400 milligrams BD for 4 months is given for a long duration. Herpes simplex virus, but it is what is the problem in herpes simplex when it is given, they latent form, it remains in the neural cell. Whether you give it has to be given for prolonged duration, maybe for weeks together. But what happens? The latent form, that remains in the neural cell and the ganglia, and which causes recurrence of the herpes infection. So this is the side effect. This is the problem which occurs in this case. The other are famiciclovir, amantadine, oseltamivir. Oseltamivir was used recently in the corona period also. Oseltamivir. Then antiretroviral agent Zerovine, tenofovir. These are antiviral agents. Microbiology and the drug selection. In acute otitis media, in the microbiology, they are generally Staph pneumoniae, H. influenzae, which account for half of the cases, Staph pneumoniae and Staph aureus for the rest. Or half of cases of otitis media, whether you give drug or you don't give drug, it resolves spontaneously without any antibiotic therapy. The pathogenicity, whether you give drug or not, if you give drug, you will get the credit. So penicillin allergy combination of erythromycin plus combination with erythromycin and clindamycin plus sulfonamide is a low choice treatment. But as I said, in 70% cases, half of the cases, the pathogens they resolve automatically in otitis media. But then other infection is persistent otitis media with infusion. This is a subacute. This is a subacute infection. Subacute infection, which is in because of poor treatment, it remains partially unresolved, so it reoccurs. So this is a case of it causes in case there is why it is persistent only because of poor infection, because of poor antibiotic coverage, it remains unresolved and it reoccurs. This is persistent otitis media with effusion. If in case there is pain and inflammation and no history of hearing loss, so antibiotics, they are generally not required. If symptom persists, one of the following as treatment can be given in case of persistent otitis media with effusion. Then chronic otitis media with infusion. This is a sequelae of acute otitis media and exhibits the thick mucoid middle ear fluid. Effusion can take months to resolve by itself. Hearing loss dictates the urgency of treatment. Laryngotomy, fluid aspiration, insertion of tympanotomy tube. It reduces the bulk of the infection and also the antibiotic use. Acute mastocytitis. The microbiology, the organism, they are Staph pneumoniae, group A, hemolytic streptococci, Staph aureus are the predominant pathogens. The Haemophilus, Proteus, Pseudomonas, they are the other. The drug of choice depends on the culture and the gram stain direct therapy and intracranial extension. But generally, we don't wait for the don't wait for the culture of the organism, and we give the treatment. Primary treatment is vancomycin, ceftriaxone, and rifampicin. The alternate therapy could be levofloxacin, moxifloxacin, IV with IV clindamycin, and IV plus rifampicin. Then, coming to the last stage, dealing with the ototoxicity. Now, with ototoxicity, they are the drug producing hearing loss and the balance disorder. The ototoxic drugs, they are, I mean, the bulk is aminoglycoside, as I told you before, aminoglycoside, antibiotic, then streptomycin, gentamicin, tobramycin. I hope gentamicin is I only, not Y. Streptomycin, gentamicin, tobramycin. These are mainly vestibulotoxic. That's why I'm written V. And the neomycin, kanamycin, and amikacin, they are mainly cochleotoxic. The other antimicrobials, they are vancomycin, erythromycin, and the amphotericin B. The other drugs, they are quinine, quinidine, cisplatinum, and the loop diuretics. All aminoglycosides, they are ototoxic and nephrotoxic. Streptomycin is more toxic to vestibular system than to cochlea, and converse is for neomycin and kanamycin. Gentamicin, tobramycin, and amikacin are the anti-pseudomonas aminoglycosides. So they cannot be, they have to be given in case of pseudomonas. They form the bulk of pseudomonas. They have to be given in case of IV injection. Genta, Tobra, and amikacin. You have to take it with a pinch of salt. A single dose of gentamicin possesses no risk to the ototoxicity, but prolonged anti-pseudomonas treatment with other ototoxic agents like cefotaximine, piperacillin, tazobactam, and levofloxacin may cause ototoxicity. There is no indication for use of kanamycin that outweighs its disadvantage of cochleotoxicity, nephrotoxicity, and is effective against pseudomonas. So kanamycin generally should not be given unless until there is a dire need. Neomycin is a common agent used in the topical eardrops. Then what are how does it occur? The risk factors, they are the impaired renal function, prolonged treatment, 10 days or more, concomitant use of, you are giving aminoglycosides, then diuretics, then furosemide, age, too old patient, generally because of poor renal function, previous history of aminoglycoside therapy, since using. These are the risk factors: impaired renal function, use of drug more than 10 days, IV antibiotic, high dose, concomitant use, you are primarily using loop diuretics, also age of the patient, poor renal function. Then how do you monitor the patient? The patient with normal serum creatinine, their treatment of 14 days or less, the serum creatinine is twice a week. With the treatment, if you can, I can pass the cursor, you can see the cursor. The patient with normal serum creatinine, the treatment 14 days or less, it is the treatment, the serum creatinine is twice a week. But for treatment more than 14 days, serum creatinine thrice a week. These are the guidelines. Then patient with elevated serum creatinine, we determine serum creatinine almost every day. Patient is rising or falling serum creatinine, then here the serum creatinine is generally taken every day. Thank you for bearing me for this long period. Now Dr. Ritu will summarize the take-home message and the summary of this presentation. Dr. Ritu, over to you.
Thank you so much, sir. I'm really overwhelmed by this presentation. It is a very comprehensive topic, and you covered extensively on different drugs, on the microbiology, even on the complications and how to monitor that, looking for ototoxicity and pharmacology and how it is integrated in otology. So the sir of different diseases, we are talking about ENT. So here mostly you talked about ear, how to manage mastoiditis, how to manage acute otitis media, chronic otitis media, sinusitis, and deep neck infections, what antibiotics to give and what should be preferred, what are first generation, second generation cephalosporins, and what are the most common organisms. Thank you so much, sir. And one thing which struck to me very evidently was that you said that ear drops are as effective as parenteral antibiotics. So that means that should become a routine. Even if we can sometimes we can do a study that we are not, that we
One of the journal, PubMed journal also.
Sir, I mean to say that we should sometimes in some sort of patients, for example, we can do a study on 100 patients that we will not give antibiotics, oral or parenteral, and we'll just give ear drops, and let us see if the ear becomes dry just by that, because if the efficacy is equal to parenteral antibiotics, that struck to me immensely. And sir, thank you so much for the presentation.
Ask the audience if they want to question something about the presentation. You can answer, we can reply to them.
So the DNB trainees, you are welcome to ask the questions if you have some queries regarding the clinical practice. So we have to integrate pharmacology in our clinical practice. We just can't. So this is the era of evidence-based medicine. So everything is evidence-based. So whatever you'll ask, it should be evident in the books. And that is the same thing which we'll like to tell you. So you don't have to follow the consultants. You don't have to follow whatever is taught to you. You just follow what you have the evidence for. And if you have any questions,
Okay, sir. I hope if everything is over, we finish the presentation, sir.
thank you so much. Should we log out?
We'll ask Dr. Nilima if we
Dr.
can.
Abhay, stop sharing the screen now.
I'll stop sharing the screen.
And can open the chat box at the right bottom. Dear trainees, you may type your questions, comments in the chat box.
Dr. Ritu, see if there is any question in the chat box. Okay, sir. Thank you, sir. If there is no questions, sir. Thank you, sir.
There are a few questions, Dr. Abhay. Can you just?
So where from can we get that PDF from Dr. Navneet?
I'll give this to Dr. Navneet today itself, sir. So, madam,
Thank you, sir.
before asking questions, just introduce yourself.
Sir?
Just introduce yourself.
Sir, this is Dr. Samar Bashir. Actually, I have joined NBEMS diploma in GMC Anantnag, Kashmir. We are in Kashmir.
Okay, I'll be sending the PDF file to Dr. Navneet today itself. You can talk to Dr. Navneet, the person who coordinates the webinar, and you can get it from Dr. Navneet.
Thanks a lot, sir. Thank you very much, sir. Thank you.
Thank you, madam.
Dr. Sarita, you may ask your question. Dr. Sarita Kumari. Dr. Isha.
Okay, sir. I'm signing off, sir. You'll be starting the next video. So thank you for allowing me to.
Thank you. Thank you very much for your time,
Sir.
Professor Abhay, for the presentation, and thank you very much, Dr. Ritu Gupta, for joining.